Hi, this is Katie Agarwal. I'm with the Southeast Texas Geriatric Workforce Enhancement Program and Baylor College of Medicine Geriatrics. I'm rejoining you to discuss more about delirium in older adults. This will be the second part of our discussion, focused on prevention and management of delirium. The objectives in this portion are to state key steps in the evaluation of a patient with delirium, that you will be able to state 3 frequent causes of delirium in older adults, be able to state key prevention and treatment strategies, as well as to look for sources of agitation and to use antipsychotic medications only when absolutely needed. When we think about the care of older adults in the hospital setting, delirium is one of the key dangers that should be avoided and managed if it occurs. In considering the inpatient setting, the 4 M's of hospital care really revolve around delirium prevention and management. These include what matters most, considering and aligning the care plan with what matters most to the patient, as well as including caregivers in all education and support. Medications, reduce inappropriate medications that may cause delirium, as well as prolonged delirium, and educate patients and caregivers about medications that are safe to take when they go home. Mentation, of course, to screen for delirium every shift in the hospital or at least daily, and to look for causes of delirium with any changes in cognition and behavior. Also, we want to support sleep without medications and ensure that patients have glasses and hearing aids to help them and to prevent sensory deprivation. Mobility is another key factor for older adults in the hospital, and it's also important for the prevention of delirium. So we really want to encourage early, safe, and frequent mobility. And of course, delirium is associated with an increased risk of falls, so it's important to prevent falls. In part 1, we covered that delirium is dangerous and may be the first sign of illness in older adults and thus need further evaluation. It's under-recognized, and a formal assessment tool should be used to assess for the presence of delirium. Older adults typically have more hypoactive delirium or sleepy, withdrawn appearance, and patients with dementia or any cognitive impairment are at the greatest risk for developing delirium. Patients with delirium will have difficulty completing tasks of attention, so inability to stay on task. But most patients with dementia should be able to complete simple tests of attention. So next steps, we need to look for and treat the underlying illness. So what are the causes of delirium in older adults? There are many different causes possible. In fact, I often state it seems like it could be the entire Harrison's textbook of internal medicine, but some of these are the most common that you should look for. Of course, an important one is infection. Delirium may be the first sign of sepsis in older adults, and so it's very important to look for infection when a patient has confusion or new altered mental status. Medications are another critical issue to look through. Look for any medications that have been given in the recent days, sedatives, muscle relaxants, sedating antihistamines, and opioids are frequent culprits. Of course, another critical issue, an acute issue at that time, is whether the patient has hypoxia or hypercarbia if they are not ventilating well. And another frequent cause of delirium is abnormal electrolytes, including sodium, calcium, and glucose. This is a mnemonic for common reversible factors in delirium. Of course, drugs, as we mentioned, and we can easily or sometimes easily change medications to try to avoid medicines that might cause increased confusion or prolong a state of delirium. Of course, treating electrolyte imbalance, and part of that is dehydration. When patients get severely dehydrated and uremic, they are no longer able to clear dangerous medications that they have in their system as well. And of course, just the dehydration itself may yield delirium. Lack of drugs, always being on the lookout for withdrawal from any type of opioid or benzodiazepines that they took at home, or perhaps antidepressants, as well as lack of medications for pain. Uncontrolled pain has been associated with the onset of delirium. Infections, as we mentioned, and reduced sensory input, so vision and hearing, are key risk factors. Of course, must always consider whether some type of intracranial event has occurred, including stroke or perhaps a subdural hematoma, but these are more rare, especially if the patient develops delirium while they're in the hospital setting. But always consider a good neuro exam and whether there perhaps has been any trauma. Urinary retention and fecal impaction are other important risk factors, and these especially will lead to agitation. And then myocardial or pulmonary risk factors. Perhaps drops in blood pressure, instability in blood pressure may yield reduced oxygen flow to the brain and thus delirium. And of course, poor ventilation. So if you are concerned that a patient has delirium using the delirium screening tools like the confusion assessment method or the 4AT, then it's critical to do a workup for underlying causes. If a patient presents to an emergency department or a clinic with signs of delirium, further evaluation must be completed, typically through admission in observation or inpatient status. In some cases where there's a clear cause of delirium known and the caregivers are able to manage this and obtain help quickly if needed, discharge to home may be appropriate, but this will require a special condition where you have really great caregivers in place that can assess and manage the situation if more problems arise. In a skilled nursing facility, if the vital signs are stable and no sign of acute life-threatening illness is present, the workup and management may be completed there, but laboratory studies should be expedited, and the patient must have heightened observation until treatment for underlying causes is initiated. So how do we evaluate for delirium? First, one of the most important features is the history. Focus on the time course of the cognitive changes. What was the association with other events, perhaps a recent surgery or changes in medication? So performing a thorough medication review, including over-the-counter medications, alcohol use, herbal medications, or other recreational drugs, being careful to go through every possible substance that was taken in by the patient. On physical exam, a neurologic exam is critical to assess for any new findings, especially asymmetry, looking for signs of stroke or perhaps bleed in the brain, which may cause an abnormal neurologic exam or some asymmetry. It's critical to really work to find a good neurologic exam, even when that may be difficult in a delirious patient. Orthostatic vital signs may be helpful to diagnose dehydration and volume depletion. It's always important to do an abdominal exam, looking for signs of pain or bladder distension. And also looking for wounds as sources of infection, really looking over the skin, looking perhaps in the mouth, sometimes abscesses. Other things that may be hidden sources of infection should be looked for when we're looking for a source of delirium. So in diagnostic studies, one of the first steps is looking for signs of infection. A CBC with a blood count, looking for signs of infection. You may also consider a chest x-ray and urine studies. These would be frequently appropriate in the hospital setting, looking for signs of infection. Would also want to check electrolytes, looking for dehydration, hypo or hypernatremia, perhaps hypercalcemia. EEG, lumbar puncture for cerebrospinal fluid, and brain imaging are not as frequently helpful unless there are some new neurologic findings or you're not finding sources of delirium on your initial evaluations. But these may be important, especially if a patient has fever and no other clear source of infection. It could be very important to do a lumbar puncture but it's not typically in the first few hours of evaluation. A CT head, a CAT scan looking for bleed or stroke should be considered more readily if there's been any trauma or the patient is on anticoagulation. Also, definitely consider urine analysis and urine cultures, but then you have to be cautious that we don't over-treat, which is a frequent thing that occurs in older adults, that if there's a little abnormality in the urine, that we assume that that's the source of delirium and miss other sources of delirium. Myocardial infection may also present as delirium in older adults, so definitely consider an EKG and troponin in selected cases. Harmful medications are a critical element that must be considered. The Beers criteria is an extremely helpful tool to use. The Beers criteria may be found on the American Geriatric Society webpage, and it is frequently updated every few years. This is a expert panel that has listed for us potentially inappropriate medications for older adults. And by using the Beers criteria, you can look through a patient's medication list and look for any medications that might cause confusion, especially those that have anticholinergic side effects. You may want to consider stopping any medication that was started or increased before the delirium onset if possible. Always consider sedatives, whether alcohol, benzodiazepines, barbiturates, hypnotics, whether the presence of them or the sudden absence may yield delirium. Overuse of opioids and muscle relaxants may also yield delirium. And then as I mentioned, anticholinergics, some of the antidepressants, as well as the sedating antihistamines and bladder agents for overactive bladder, muscle relaxants, are all anticholinergic. Antipsychotics are also very anticholinergic and may add to delirium, as well as anticonvulsants and H2 blockers like Pepsid. But these are perhaps less common. Anticonvulsants definitely should be considered, though, if perhaps the patient has a high phenytoin level or perhaps might need a lower dose of their anticonvulsant medication. 1 in 3 cases of delirium in hospitalized medical patients aged 70 or greater can be prevented. So how can we help? Well, there are many ways to help, and these little icons are great ways to think about it. The sun is important there to help with day-night cycles. This is a critical element in the hospital. We interrupt sleep, we make it difficult for patients to sleep, and delirium worsens a patient's normal sleep cycles. So it's very important to have bright lights on during the day, try to get patients up and active during the day, and then help with lower lights at night. The glasses, for glasses and hearing amplifiers, so that we can help patients have good interactions with their situation that they're in and be clear with what is happening around them. Prevention of urinary retention as well as constipation and fecal impaction are also critical elements which can cause a lot of discomfort and may yield infections. Good nutrition, so making sure to help patients drink and eat properly during their hospital stay and not get dehydrated is another factor which helps to prevent delirium, as well as early mobility. So really helping to make sure that patients get up and moving as soon as possible is an important issue that helps to prevent delirium. And the location is to help remind patients of their orientation, where they are, what's going on. I find it's helpful even just walking into the room, introducing myself and saying, "Hi, I'm Dr. Agarwal. I work here at this hospital, and I'm coming to see you today. It's a lovely Tuesday outside." Just in your introduction, you can give a nice reorientation to the situation. Sharon Inouye published a wonderful study in the New England Journal of Medicine. This important study looked at 852 medical patients aged 70 or older admitted to the hospital. It focused on a program called the Hospital Elder Life Program, which Dr. Inoue developed, and it's a group of volunteers that do interventions to help prevent delirium. These include cognitive reorientation, talking to patients about what's going on today, bringing them newspapers, a non-pharmacologic sleep protocol, which I highlighted because it had 100% adherence in the trial, and I would argue is one of the most important factors in this trial because of the level of adherence. In this, the patient was not giving sleep aids until they had first attempted a non-pharmacologic sleep protocol, including a warm milk or herbal tea, back rub, and light music. Other important features of the interventions to prevent delirium were mobility, helping patients to get out of bed, sit in chairs, and walk, giving them glasses and hearing aids, or giving them hearing amplifiers if they needed them, and a hydration program in which they helped patients make sure that they had water and liquids close by so that they could drink, and assist them with eating and drinking. This intervention decreased the incidence of delirium by 1/3 in this population. And I think it has taught us a lot about the importance of non-pharmacologic interventions and the quality of our care in prevention of delirium. So the best treatment for delirium is actually prevention. But fortunately, these same features which were important to prevent delirium is also what we use to treat delirium. So we will use the same interventions: early mobility, day-night cycles, helping people to sleep without medications, good hydration. All those things are very important to treat patients who also already have delirium. And at the same time, you're looking for what are the causes, what are the things that we can treat, what are the reversible conditions that we can treat, while we're using the multifactorial non-pharmacologic approach at the same time. So right up front, one of the most critical issues then is finding that underlying cause and looking for multiple causes. Don't stop at just one. Frequently in older adults, there are multiple things that add together to yield delirium. And then we want to anticipate and prevent other precipitating factors, help with behavioral and sleep disturbances, avoid any harmful medications which might prolong delirium, and educate families about the severity of delirium, the anticipated time course, and complications, and help them to understand they can play a critical role in helping patients recover from delirium by helping the patient with their day-night cycles and helping them with their orientation and cognitive interactions. So a little bit more, the non-pharmacologic interventions that are critical include orienting devices, clocks, calendars, really working hard to help with day-night cycles, including sunlight exposure during the day with windows allowing in sunlight and bright lights in the day, helping them be darker at night, encouraging social engagement, ensuring that patients have their eyeglasses and hearing aids or hearing amplifiers to help them with social engagement, mobilizing patients, helping them to burn energy and to be active and to do things during the day so that they can sleep at night, not allowing them to sleep all day and thus getting their day-night cycles interchanged. Really helping with adequate oral hydration and helping people to eat, and of course educating and supporting the family. Sleep hygiene is a very difficult issue, and of course it's just becomes more difficult as the patient loses more and more sleep if their day-night cycles are disturbed. But you really want to limit and avoid any sedatives as much as possible because they will prolong delirium. Non-pharmacologic things, of course, think about using earplugs, eye covers, quiet spaces. Those are all very important to help people sleep. as well as the things that were used by Dr. Inouye in her trial, like warm milk or herbal tea, music, back rubs. If needed, as a second line, you may try medications. At our hospital, we use Ramelteon, which is a melatonin receptor agonist, or you may use melatonin if it's available at your hospital, perhaps 3 milligrams or so, 3 milligrams at night to help with the day-night cycles. Trazodone has been recommended frequently in the past at low doses of 25 milligrams for sleep. There have been no trials for using this as a sleep aid in a hospital setting. Thus, this is really based on expert opinion and anecdotal evidence, but it is another second-line agent which might be used. It's strongly recommended to not use sedating antihistamines like diphenhydramine, hydroxyzine, also to avoid the sleep aids like zolpidem, which have been clearly associated with falls and delirium. Benzodiazepines, studies have shown that the greater doses of benzodiazepines used in the hospital are linked to greater incidence of delirium, and of course tricyclic antidepressants, which are highly anticholinergic. This is a critical issue, of course, management of agitation. What do you do if a patient who is delirious develops agitation? And I think the most important thing that I really want you to remember is that agitation is not the same as delirium. Agitation is a sign of discomfort. Something is bothering the patient. The delirium, the altered mental status, causes the patient to not be able to report their complaints, to not be able to ask for assistance appropriately, or perhaps explain to you what is bothering them. But it is not the same as delirium. It's not the same as agitation. They are not equivalent. So agitation is really a sign of discomfort. And so your job when a patient is agitated is to look for the source of agitation or discomfort first. What is bothering the patient? And this may be pain. Frequently in a postoperative patient, you might consider, have they had pain medications? Do they have untreated pain? Another frequent source of agitation and discomfort in the hospital are shortness of breath. Of course, this is a very difficult one to manage, but do they need diuresis? Do they need extra oxygen? And then, of course, urinary retention can be extremely uncomfortable, and you may see this very commonly in older adults in the hospital, as well as severe constipation may also be another source of discomfort. So the first line in management of agitation is trying to be a detective and understand what is bothering the patient. Environmental interventions are also a critical part of the treatment. So trying to understand perhaps if they need to be positioned differently, perhaps a splint or something else may help a source of pain that's coming from a limb, that has had surgery, or the way that someone is seated in bed, and make sure that they're not having back pain or pain on a decubitus ulcer or something. So really trying to think about the way they're positioned, the way they're sitting, looking for other things that you can do to help a patient be more comfortable. Are they too cold? Are they too hot? Also consider having a family member or a sitter to stay with them if at all possible, and avoiding any physical restraints which will cause more distress. The 3 R's is a great strategy for managing agitated behavior. First, to reassure the patient, help them know that they're in a safe place, that they will be cared for. I often remind them that you're here in the hospital, we're here taking care of you, you've been sick, but you're getting better. Just trying to help them know that they are in a safe place. Your family knows that you're here and they are coming. Try to help reassure them that they are in a safe place. And then reconsider. Consider how things appear to that patient. Perhaps if we consider their viewpoint, we might understand why they are so distressed. And so try to consider how things might appear to the patient and what we can do to change things. Sometimes when I feel like they're seeing shadows or illusions due to things in the room, I'll turn on the lights so that they can see better what is around them. Or perhaps if they're hearing noises from the hallway, help them go look in the hallway and see that it's just other nurses that are taking care of patients. And then redirect. So it's always important to try to redirect, distract, move on to a different topic. If a patient is focused on perhaps a visual hallucination that is in the room, I would advise to not argue with them about their reality. They are experiencing that hallucination, but try to help them focus on something else. Or perhaps if they're really concerned about something that is really stuck in their head and they kept perseverating about some issue, maybe help to focus on something different. I'll never forget one of the best teaching moments I had. The nurses taught me. There was a patient who was just so agitated one morning, early in the morning, about 6 a.m. He felt he needed to go to work. He had to go to work. He was so angry at the nurses for not letting him go to work. And so a nurse brought him out into the hallway onto a bench. And it did not look like a bus bench, but he sat on the bench with her. She said, "Oh, let's sit here on this bench and let's see if the bus comes so we can get you to work." In just a few minutes, she brought him a nice warm cup of tea, and she said, "You know, I think that bus is running late today. Why don't we go drink a warm cup of tea, and we'll come check on it again later." And, you know, just by not arguing with him, she brought him some tea, and then she brought him some breakfast, and we were able to get past this, this problem. But I don't know that we would have had a successful outcome otherwise without that creative thinking. There is no medication that really treats behavioral disturbances, whether that's due to delirium or perhaps to dementia. And so it is very difficult to try to treat agitation with medications. And there are many risks involved. So some patients you really do want to avoid antipsychotics. And of course, as I mentioned, pain management is the first line of treatment for agitation and distress. If you feel that if the patient perhaps does have truly psychotic features and is a harm to themselves or others, sometimes you really do need to use a medication, but you want to use the lowest dose possible and use it as infrequently as possible. So you would typically start with a low dose as needed of haloperidol at 0.5 milligrams, either orally or intramuscularly, and avoid scheduling antipsychotics if at all possible. I mentioned using haloperidol first at this very low dose because you can give another dose, but you can't take it away. And so you want to use low doses to not oversedate the patient. And another big issue is that the prolongation of QT intervals causing arrhythmia are related to the dosing of antipsychotics. So the higher doses that are used will increase that risk of QTC prolongation. And that is part of the reason that I did not mention using haloperidol intravenously. Haloperidol is not FDA approved for intravenous administration due to issues around concerns of developing severely prolonged QT intervals and fatal arrhythmias. So it's important to try to avoid intravenous use of haloperidol. If you do, it should be used in very low doses, at less than 3 milligrams or so per day total. And you do want to monitor for prolongation of the QT interval and, of course, extrapyramidal side effects after starting an antipsychotic. A typical rule of thumb that is that if the QT corrected is greater than 450 milliseconds, that you should try to avoid antipsychotics if at all possible. and if it's greater than 470 milliseconds, should really try to avoid, especially being very, very careful. Some patients will have more problems with antipsychotics, like patients with Lewy body dementia or Parkinson's. You may want to use a second-generation antipsychotic. And you do not want to give benzodiazepines for agitation related to delirium unless you feel that it's due to alcohol or benzodiazepine withdrawal. There are many other antipsychotics that are out there, especially if the patient will take oral medications. For example, aripiprazole is not thought to increase the QT interval as long as some of the other medications, and some may have less extrapyramidal side effects and thus be safer for patients with Lewy body dementia or Parkinson's, like quetiapine. Another important issue is don't forget the caregiver. The time course of delirium is not predictable. Some patients may resolve in a few days, while some may have symptoms that last for weeks or months. And so it's really important to educate the caregiver about what's going on and help them to support the patient. It's also very important to tell caregivers that some patients may improve, and most will improve, but may not recover back to their baseline cognitive function that they had prior to this episode of illness. So it will be important for caregivers to be involved and be available and to assist them with their needs for the next several weeks after discharge home until they feel as though they have normalized. So as patients improve, try to explain that need for increased assistance and support until the patient has a full physical and cognitive recovery from their illness. So take-home points: delirium is dangerous. Frequent causes of delirium in older adults are medication, infections, and metabolic abnormalities. The treatment of delirium is finding and treating the underlying causes while supporting the patient through non-pharmacologic interventions. Good non-pharmacologic techniques which help prevent delirium are required to support patients during the management of delirium as well. And agitation should be considered as a sign of discomfort, and look for sources of discomfort in patients that seem agitated and distressed when they are delirious. Here are some valuable resources which we'll also have in our delirium toolkit for you. Some of the websites listed are extremely useful to find resources, including the NIDUS Delirium Network resources. ICUdelirium.org has wonderful resources for patients and for providers. And Geriatrics at Your Fingertips has a wealth of resources, and this is free, and you can find it through the American Geriatric Society webpage. Thank you for your attention today. I hope that we have been helpful, and I encourage you to please fill out our surveys, especially these are needed for your continuing education credits. If you are a trainee who is not getting continuing education credits, it's important to do the first survey here, the demographics survey. And then also it's important for all to do the satisfaction and knowledge survey, the second survey, as well as a survey evaluating my effectiveness as a presenter to you today. So thank you for taking the time to spend with us and to learn about delirium in older adults. Thank you.